Good morning, everyone. I want to thank Claudia, who's not here yet, for inviting me. So over the next 20 minutes, I'm going to talk about acute kidney injury in patients with liver disease. These are my disclosures. So renal dysfunction in patients who have cirrhosis, it's a bit challenging. And the biggest challenge we face is trying to determine whether this is an acute event or is there some underlying chronicity that's involved in these patients. It's very difficult sometimes to even appreciate the underlying severity of their kidney disease. And despite all the discussions about biomarkers, after all these years, there's still serum creatinine ends up being the only biomarker that we really use to determine renal function in these patients. But as you all know, that the serum creatinine is not very accurate in determining the severity of their kidney disease. And a lot of it has to do with the underlying liver disease. You can get, these patients tend to be fluid overloaded, so you can have some dilution in the serum creatinine. There's interference depending on what kind of assay you use for the serum creatinine. And ultimately, all the serum creatinine, the creatinine clearance, the eGFR equations that we use tend to overestimate the function in all these patients. So if you look at the data over the past, really 2 decades, trying to determine what the prevalence is, you can get results on the anywhere from 10% to as high as 50%. And all of this has to do with the patient population. Are you looking at inpatients, outpatients, ICU patients? Is it after patients with SBP? And the biggest flaw with all these data is that defining AKI in all these papers has really been variable, mainly focusing on a creatinine of 1.5 as the definition of AKI. But again, the definitions tend to be different in all these patients. This was a recent article that just got published from the Canadian database, and if you look at here, basically they show, if you look here, about 36% of the patients who are admitted to the hospital with cirrhosis end up with AKI, and they've broken it up to the various stages, which I'll talk about later. So where does this all start? In order to kind of understand the current definition now, you have to kind of go back to see where it all started. And it actually started back in Italy in the 1970s. And this was the first definition of hepatorenal. This was the first consensus meeting that came out. And they defined the renal insufficiency as a creatinine of 1.5, and looking at the data that even exists in the liver patients, there's actually no data to support a 1.5, and it was just kind of arbitrarily picked as defining AKI at that time. But what's very interesting is that in their definition of hepatorenal, they did acknowledge that these patients may have some element of tubular dysfunction, and that these patients tend to have a low urine volume, and again, that they can have granular cast, so kind of starting to suggest that there may be some interrelationship between ATN and what they thought was hepatorenal syndrome at that time. This then got in the 1996, so we're about 20 years, approximately 20 years later. The Ascites Club, the International Ascites Club, updated this. They still kept the creatinine of 1.5. They added a creatinine clearance here. But again, in the minor criteria, they did still include a urine output that was on the low side to consider these patients for having hepatorenal syndrome. This then, again, about a decade, about 10 years later, this got further updated. All the minor criteria was removed. They added this absence of proteinuria and hematuria in there as a criteria, but again, the creatinine of 1.5 was still as part of the diagnosis of hepatorenal syndrome. So in 2010, AKI had its 8th consensus meeting on hepatorenal syndrome. It was a international multidisciplinary group of faculty, and here we suggested that basically to use at that time the Aiken criteria was out, to use the Aiken criteria as defining AKI, and that hepatorenal syndrome type 1 should probably be just part of AKI in these patients. And the question then became whether HRS type 2 should be part of CKD, depending on how long it's been going on. And we recommended to stage it again to get rid of the creatinine of 1.5 and just to stage it based on the AKI criteria that was currently at that time. As you can see here, it's only based on the serum creatinine. The urine output at that time, there was a big discussion with the hepatologist that at that time didn't want the urine output to be included as a defining point in AKI. We also suggested this term that we called hepatorenal disorders, and basically it was to suggest that if you look at the definition for hepatorenal syndrome, it's an absence of proteinuria, it's an absence of any kind of underlying renal disease, and what we suggested or recommended that there can be this understanding that all patients with hepatorenal have a completely normal kidney function. May not be that true in patients, especially now that there's a higher percentage of diabetics in the nation that with cirrhosis, that they can have underlying kidney disease, that these patients can ultimately develop AKI, they can develop HRS as a form of AKI, type 2 HRS, and these patients then can ultimately go develop HRS1. So again, it takes away that whole notion that the urine has to be completely normal in order to develop hepatorenal type 1. And if you look at the studies now, all the studies on terlipressin or any other medication has basically eliminated this group of patient population and has only focused on kind of here with no kidney disease and HRS1. Since our publication and the consensus meeting 2010, you can see here, there's a lot of publications that have been looking at the AKI criteria in this patient population. Again, it's only the serum creatinine criteria, and you can see they've all been showing, validating that as your AKI stage goes up in these patient population, your mortality tends to go up also. So this led to 2015, the International Ascites Club decided to, with all the data that was out there, to redefine AKI and hepatorenal syndrome. And you can see here, this is the IAC definition of HRS AKI. So they have acknowledged now that HRS is a form of AKI. The creatinine of 1.5 has been removed, and instead it's been a diagnosis of AKI based on the, it says ICA criteria, but it's basically the AKI criteria of stage 2 and 3, that if you have that, they've still kept the rest of the HRS definition regarding absence of shock, absence of proteinuria, but they did acknowledge here that patients who fulfill these criteria can have some structural damage such as tubular. Again, starting to now go back to the original definition that there may be some either underlying ATN or there may be some structural damage like IgA, diabetic nephropathy, and on top of that developing HRS. And again, similar to our consensus meeting at AKI, the staging, they've kept the staging as such. They defined it as again, a creatinine of 0.3 milligrams, and the baseline serum creatinine of less than 3 months. But what's missing from this definition and from the AKI that we had was the urine output definition. And in this paper, they state that the use of a reduction of urine output in patients with cirrhosis really is a problem, that these patients are frequently oliguric, they're sodium avid, and yet they, in the judgment of the co-authors here, that the GFR is normal, and that these patients may have an increased urine output of diuretic treatment, and ultimately because it's difficult to accurately measure the urine output, that this really should not be considered as a definition as part of AKI definition. So we had a consensus meeting about 2 years ago, so this was right after the IAC, and this was we covered all aspects of the ICU patients of a cirrhotic patient. This was the renal group, and you can see here wonderful Dr. Kellum, Dr. Mehta, they're here discussing their version of the renal. Then you have the hepatologist, Dr. Pereguinis, and Dr. Lupe Garcia, who were the hepatologists also in this group, and Dr. Davenport, who was their group leader. And it's supposed to be a consensus, so here we have Ravi and John saying that this looks really good. Let's just add the urine output, the hyponatremia, and fluid retention to the algorithm. of when to suspect renal dysfunction in these patients. And you have Lupe and Paris saying, well, this looks great. Let's just remove the low urine output, the hyponatremia and fluid retention from this algorithm, and it will look great. And the group leader who's sitting on the corner here was just saying that, do these folks know that it's 2 a.m. in the UK? He had just arrived, and he was basically barely functioning. So after a lot of fighting, 2.5 days in the consensus, you can decide who won, but anyway, it went with the serum creatinine. We did put a urine output section to this, and we did put a statement that although the severity of oliguria and the diagnosis of AKI has yet to be validated in these patients with cirrhosis, if you notice that the urine output is dropping, if they're anuric, then you should consider these patients as having AKI until proven otherwise, regardless of any rise in the serum creatinine. And so this is, Andy Rooney is a writer, a newspaper writer who was in the US who passed away. He said, I've learned that to ignore the facts does not change the facts. And so the facts are urine output is important in outcomes in these patients. This is from Pittsburgh, 32,000 ICU patients that was published 2 years ago. And you can see here, if you have no AKI based on serum creatinine, but you have a urine output AKI, and you compare this to no urine output AKI staging, but a serum creatinine staging, that actually by stage 3 of urine output, your mortality is much higher than if you only have a serum creatinine AKI. And if you go across this way, as your urine output decreases, your staging goes up, your mortality goes up. This is in all ICU patients. This is just hot off the press from the same group in Pittsburgh, the same patient population. They now looked at their liver population, and those 32,000 patients, there's 3,000 with chronic liver disease, and they found exactly the same, that as your urine output staging goes up, even if you have you don't meet the serum creatinine criteria, that your mortality will go up, and in fact, it's even higher than if you just have a serum creatinine. So it does mean that the urine output is important, the drop in urine output as a criteria, and they've shown also that the survival over 1 year, if you meet the criteria of AKI with either the serum creatinine stage 3 or urine output stage 3, your survival is very similar. But if you have both of them, if you meet both criteria, that your survival is much worse at 1 year. So differential, once you've defined the AKI, that these patients have AKI, the biggest problem is trying to determine, really, do they have pre-renal HRS or ATN? And we use these kind of markers that we believe, okay, the urine output may be helpful, the urine sodium may be helpful. Do they respond to volume? Ultimately, a renal biopsy is the final diagnosis, but the majority of these patients are coagulopathic, so we don't do a renal biopsy. So trying to differentiate between hepatorenal and ATN may not be always straightforward. And this is it's a small study, but it was from University of Florida, from Mayo Clinic in Florida. And they biopsied patients who had renal dysfunction, and for the etiology was unknown. And you can see here, they had about 13 who had ATN, about 11 of those patients, minimal findings, so probably these patients had hepatorenal. But what was striking is that what we kind of, as nephrologists, say, well, if your fractional excretion of sodium is less than 1%, then it's definitely not ATN. And you can see here 87% of their patients with the ATN group had a FeNA less than 1%. And in fact, this is a biomarker study from Yale that looked at, based on biomarkers, this was not biopsy-proven data, but they looked at the patients that they felt had pre-renal, HRS, and ATN, and you can see here the fractional excretion of sodium of all these patients was less than 1%, and you can see here what they found. The difference was that people with hepatorenal had severe vasoconstriction, that their fractional excretion was less than 0.1, but their ATN group was 0.3. So again, just saying that it's less than 1 and it automatically means either pre-renal or HRS, they're proving it that that's not the case. And they looked at urine albumin as a marker, and again, they saw that these patients, there was a big difference in the urine microalbumin excretion. I'm not going to go so much into treatment, but ultimately, These patients, a lot of them will require dialysis, renal replacement therapy, whether they have AKI for other causes or AKI due to the hepatorenal. And the big question we're faced as a nephrologist is, should we dialyze or not dialyze these patients? There's a lot of, again, fighting sometimes between the hepatology service, the nephrology service, and sometimes the critical care service. And the thought has always been, well, if they're a transplant candidate, then let's go full support for these patients. But if they're not, maybe we should just call palliative care for these patients. And that idea has been based on this paper that was about over a decade ago, suggesting that, well, patients with hepatorenal syndrome, they just ultimately die short of a transplant, and so maybe these patients should not be offered even dialysis at this time. The problem is that we really, again, without a kidney biopsy, we really can't be sure whether these patients have hepatorenal syndrome. And in fact, the outcome of these patients may be different. If you have even parenchymal nephropathy, these patients they do much better. If it's sepsis AKI, they're a little bit better. So it's not that every patient who has AKI that we think is HRS is going to do poorly. So to not offer them dialysis is something that we need to revisit in these patient population. And in fact, the European, this is the EASL-CLIF consortium, have come up with this prognostic factors in acute on chronic liver failure, which are the majority of these patients who end up in the ICU typically have acute on chronic liver failure. And what they have suggested and found, and it's very similar to the general ICU population, is that if you have and I'm not going to go into the details of the CLIF scoring system, but if you have 1 or 2 or 3 organ system failure, and they've defined these very nicely in their paper, you can see here within a week, if you start to progress, then your mortality is very high. And maybe in those patients, by the end of 3 to 7 days, if they're progressing, not to offer something like dialysis, or if you do, to start talking with the families for withdrawal. Versus if you if you have ACLF stage 3 for whatever reason, for sepsis, now you're multi-organ failure. But if within the first week you actually start improving, your outcome can be quite good. And so these patients should be considered for renal replacement therapy, and to get away from the notion of, well, if you have hepatorenal syndrome and you're not a transplant candidate, not to offer anything. And again, we have to get away from that kind of mentality. And on that, I will conclude with what the liver said to the kidneys as they were failing, that you're in my thoughts. Thank you.